It is now my pleasure to welcome Isabel van Gelder from the University Medical Center Groningen to speak about subclinical device-detected atrial fibrillation. Isabel, patients with atrial fibrillation may have symptoms, but many do not. What do we know about the consequences and clinical relevance of asymptomatic episodes of atrial fibrillation?
A very important question and my first take-home message. Symptoms do not matter. Whether or not they are present, the occurrence of stroke, heart failure and other AF-associated adverse events occur. They do not depend on the presence or absence of symptoms. So asymptomatic atrial fibrillation does have the same consequences as symptomatic atrial fibrillation.
One opportunity to identify asymptomatic atrial fibrillation episodes is during the regular follow-up visits of patients with pacemakers and other implant devices. We talk about atrial high rate episodes. Not all of them, though, are atrial fibrillation. What should the cardiologist look for and how should we react?
Well, Carlos, indeed, not all atrial high rate episodes are always atrial fibrillation. And first of all, those ARA episodes need to be inspected because they may be artifacts. So indeed, not all ARA is indeed atrial fibrillation. And then once it is atrial fibrillation, then we call it subclinical atrial fibrillation, not ARA anymore. Subclinical because it has been detected by an insertable cardiac monitor or wearable monitor and confirmed to be atrial fibrillation. And once it is subclinical atrial fibrillation, it is a class 1B recommendation now in the present 2020 AF guidelines to start a complete cardiovascular evaluation and to follow those patients during the rest of their life and to look for progression of the subclinical atrial fibrillation episodes, especially when they last, for example, longer than 24 hours or become clinical atrial fibrillation.
Isabel, if indeed subclinical atrial fibrillation is detected, can we rely only on the duration of the episode to determine the risk of the patient, or should we consider other factors?
On the left, it is the stroke risk in patients with clinical atrial fibrillation, either paroxysmal, persistent or permanent atrial fibrillation. On the right, it is subclinical atrial fibrillation, data from the ASSERT trial. And note the enormous difference between the two entities, clinical on the left and subclinical on the right. And what you also clearly can see on the right side, that is only if subclinical atrial fibrillation lasts more than 24 hours, then the risk on stroke more or less becomes comparable as this clinical AF stroke risk. So I look at duration in my subclinical AF patients, but even more important at the number of comorbidities, and that we assess using the CHETS-FOSC score.
Now, a very important point to our audience. What is your advice in whom to start anticoagulation if only subclinical atrial fibrillation is detected?
Well, this is a very difficult question, even for me after all those years. And why is it so difficult? Because there are no data. There are no data from randomized clinical trials. So at the moment, there is no firm evidence that patients with subclinical AF actually benefit from oral anticoagulation. And that, of course, is the advantage, the benefit, reduction of stroke versus the disadvantage, the occurrence of bleeding. That is where it is all about. But we are quite lucky because later this year we expect the data of two large trials, the NOAA AFNet trial and the Artesia trial. Well, but for present, an advice and what I always do in my clinical practice, I look at the duration, and when the duration is long, for example, above 5 hours, and I look at the CHETS-FOSC, and when that CHETS-FOSC is high, for example above 4, then I discuss with the patient and at least I give the advice to the patient that it could be of benefit, an advantage to start anticoagulation, but of course I never do it on my own, always shared decision making.
Smartwatches have become widely available and may alert individuals about asymptomatic episodes of atrial fibrillation. I think it is important that we talk about this. How reliable are such devices, and what is the appropriate further management when possible atrial fibrillation is detected?
This is very important because we now have a lot of smartwatches available, and there are two types of smartwatches. One is PPG based and the other one is EKG based. If it's an EKG, then it is nowadays much easier to use. But the PPG based smartwatch, which are most of them at the moment, they are not EKG based, so do not have a definitive diagnosis of atrial fibrillation. If atrial fibrillation is suspected on such a PPG-based device, then we need confirmation by an EKG or a single lead or continuous recording, but anyway, by a kind of an EKG recording.
One last but important question, Isabel. Can smartwatches be a reliable diagnostic tool in patients who report occasional symptoms or in patients in whom atrial fibrillation is suspected as a cause of embolism? In other words, can smartwatches be a replacement for Holter ECG recordings in these scenarios?
At the present, especially to catch symptoms and to catch the rhythm during symptoms, it's very easy to use. And then, of course, we should go for EKG-based smartwatches. It's a very good tool to look for the rhythm at the moment of the symptoms. And then quite often it's not the case, that's not atrial fibrillation at all, but it is only one extra beat or so. In patients with an ESUS, an embolic stroke of unknown source, indeed it can also become an important tool.
Thank you very much, Isabel. This was excellent information on a very important topic.